I'm Yuvaraj, a pain fellow from Toronto General Hospital.
Sam Narouze, pain physician from Akron, Ohio.
Like Narouze, I have a few questions for you.
Sure.
What are some unique challenges PNS face that ACS does not?
First, I think there is room for a PNS in general because spinal cord stimulation, usually we perceive it as a minimally invasive procedure, but it's a device that we place in the small lead that we place in the neuroaxial space, and it can have potential complications from infection or bleeding, which can lead to bad morbidity. Peripheral nervous stimulation on the hand, as the name implies, is peripheral. So all the complication usually is very mild, superficial infection. So it won't cause significant morbidity. So there's a demand and the need for it. There's a gap that we'll need. However, we have a long track of good results with spinal cord stimulation over the past many years. Peripheral nerve stimulation, although it was started late, very early, it's not popular because not everyone is comfortable, lack of training during fellowship. There is perceived lots of migration with those peripheral nerve stimulation. The indication is still not clear. So how to apply it, patient selection, and the technology itself, although there are many recent advances in this area.
Yeah. And the next question is, do you see any big changes coming for PNS in the next 5 years?
I believe so. I believe that the more you want to be less and less invasive, I think it's a good idea to stay away from the epidural space if you can. So it depends on the indications. If it's an isolated nerve injury, CRPS, post-herpetic neuralgia, why the need to invade the epidural space if you can target this isolated nerve? So as more as we have more education improving in the technology, I will see the indication for it will be wider and wider, and physician will be more comfortable offering this new modality of treatment to help pain patients.
For someone looking to break into the field of PNS, what indication have you found PNS most successful in treating currently?
I would say it's peripheral nerve, so it has to be a peripheral nerve. It has usually we do it for pain, sensory. So you target sensory nerves. Try to avoid, if it's a mixed nerve, you need to use the perfect setting to just modulate or stimulate the sensory part of the nerve, not the motor part. So as I said before, usual entrapment syndromes, like occipital nerve entrapment, which it will be a good cause for chronic intractable headaches, intractable of other nerves, like the ilioinguinal, iliohypogastric in the groin area, usual scar tissue from hernia surgery, post-herpetic neuralgia with the intercostal nerves. So isolated nerves. You can do it for post-amputation pain. You can target the femoral nerve, the sciatic nerve. You can be more specific to the target. Epidural, you stimulate anything below whatever the level. So you can stimulate the posterior column. So it's bilateral. You can be unilateral, but it's more wider area. So if the disease is more localized to a single plexus or single nerve, my first choice would be really peripheral nerve stimulation.
Okay. The one last question. What is the one takeaway you hope others will take from your workshop at this meeting?
I would say we always say it's patient selection, I think, because the technique, I think it's easy to learn, easy to master. It's not difficult, like accessing the epidural space. You might need to be clever in how to anchor it right. There's no much tunneling like the epidural space. But it's patient selection. Which patient will be a good candidate for it? Do you need to do a trial if you're in doubt, or proceed directly with the implants? So we'll discuss those issues in the workshop. I think patient selection and monitoring the patient to optimize the comprehensive treatment. So patients still, I mean, it's not like a holy grail. They will need still some support, so you can implement physical therapy. The idea that you are taking the edge of the pain off, so the patient can be more productive, he can more participate in physical therapy and rehabilitation program. So I would say the most important thing, I would argue it's not technical skills, it's more patient selection, monitoring the patient to early detect any adverse effect or complication from your device.